Hi, everyone. Welcome to Citywide Psychiatry Grand Rounds. Thank you for making the time to join us today. Before I begin, let me start with an online land acknowledgement. I would like to begin with the acknowledgement of the land on which we work, study, and live. Before I read it, I want you to take a moment to situate yourself and think about the land under and around you. I recognize many of the indigenous nations that have a long-standing relationship with the territories and the sites the Department of Psychiatry is located and established. We acknowledge the presence of the traditional treaties under many indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and Wendat people. Today, this land is home to many more diverse First Nations, Inuit, and Métis people, and we're grateful to have the opportunity to work and gather in these territories. I acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit and the Williams Treaty covered by multiple Mississauga and Chippewa bands. A since this is a virtual gathering, a singular land acknowledgement does not capture the richness and distribution of our many locations. There are a few places on Earth someone before us has not called home. So thank you for allowing me to do that. And today's Citywide Psychiatry Grand Rounds, I would like to welcome Unity Health St. Mike's, our co-host for this event, and thank you for being the co-host today. And we have a really wonderful presentation today on interventional psychiatry, clinical and emerging perspectives by Dr. Venkat Bhat. And I'm thank him for being here as well. Evaluation links will be sent to attendees after the presentation. Your feedback is really appreciated. Next Citywide Grand Round is on November 24th. Level 5.
Well, thank you.
Sorry, I just muted myself because there was an announcement. So without further ado, I'm going to pass it on to Dr. Karen Shin, who's the PIC Physician-in-Chief for St. Mike's Hospital. Go ahead, Dr. Shin.
Thank you, Raj. It's really a pleasure to co-host the Citywide Grand Rounds this week and to welcome one of my colleagues, Dr. Venkat Bhat, to present. Dr. Bhat is an assistant professor in the Department of Psychiatry at the University of Toronto. He's the medical director of the Interventional Neuropsychiatry program at St. Michael's Hospital, which offers novel interventions for treatment-resistant psychiatric disorders. And there's 3 pillars in which there are clinical interventions and also research interventions, including novel pharmacology, brain stimulation, and digital therapeutics. He's also well connected amongst other organizations and a lead in the healthcare analytics AI theme within the Institute of Biomedical Science and Engineering Technology and the member of Faculty of Biomedical Engineering, Toronto Metropolitan University. He has really had a vision of what would make a difference for treatment-resistant illnesses and created clinical interventions that are both emerging and novel, and also a research program that really helps to understand treatment responses with these emerging interventions. So without further delay, thank you very much and look forward to hearing your talk, Venkat, and I'll hand it over to you.
Thank you, Karen, for the kind introduction. Thanks, Raj. So I'll get started with my presentation. And, as I was preparing the presentation, I was really thinking, do I go for depth or do I go for breadth? Each of the topics within the pillar is a talk by itself. So I decided to go for breadth, but also to tell stories and to give pictures. A picture is worth 1,000 words. So what you'll see with the presentation is a lot of pictures and a lot of stories. The icons you see there, DIG stands for the Digital Interventions and Intelligence Group, which I lead, a multi-institutional group, and IBEST is an institution which brings together Faculty of Engineering and Computer Science at TMU, along with St. Mike's. So I'll start off with the picture that you see on the right, which is emblematic of our program. So this is by Albert Gary, who felt intense sadness and isolation with the loss of his wife and went on to create this piece of artwork. It's called The Hollow Man. It's in Lake Geneva, Switzerland. It represents melancholy, the emptiness which one feels with grief, the void that grief leaves, but also hope, the struggle to maintain hope, and the shared challenges which everyone, particularly those with mental illness, face. The overarching theme for program development for us within the interventional program has been to make a difference in the lives of patients with treatment-resistant mental illness, and that's what this actually depicts. So with that, I'll move on. This is the customary disclosure. So I'll give you a minute to take a quick look. Moving on. So by the end of this presentation, I'm hoping to give you a quick overview about clinical aspects of interventional psychiatry, an overview of some research paradigms within the field, and also acquire a deeper understanding of a few specific emerging treatments. This is how I'm going to do it. So I will give you an overview in the first 15 minutes about how we have developed the interventional program at St. Mike's. And you will get a sense of the different components. An interventional program does not need to have all the components which we have. It doesn't need to be done the way we have, but there are components there which are common when one is thinking of developing or bringing together existing programs into an interventional program. I'll touch upon some conceptual paradigms in interventional psychiatry and give a brief clinical overview of specific treatments, and then some new exciting and emerging treatments which are a couple of years in the making. So I'll go through things in this order. All right, so let me start off with the components and organization of the interventional psychiatry program at St. Mike's. So we have, as Dr. Shin mentioned, at the outset, we have three pillars. We have a pharmacological pillar, we have a neurostimulation pillar, and we have a digital pillar. In the interest of time today, I won't be speaking about the digital pillar. We're focusing on the pharmacological and the neurostimulation pillar. Each of them has a clinical arm and a research arm, and I'll selectively speak about a few of the treatments within both. On the clinical side, I'll be speaking a little bit about ketamine. Again, I'm going to give a historical overview, as to how we've come to the point we are now, with some key studies to highlight the timeline. And then I'll speak a little bit about TMS. And then on the research side, I'll focus on the ones I've highlighted in green: nitrous oxide, stellate ganglion block, psychedelics, which I won't be talking today. It'll be more about nitrous oxide and stellate ganglion blocks, and then take-home neurostimulation. So we have a single referral for all the clinical and research offerings within the program, which you see here. Now, I want to convey to you the idea of the interventional program. We are like interventional cardiology or interventional neurology. The focus is on treatment-resistant mental illness, people who have failed first, second, third-line treatments. We do not take over the care of patients. Just like interventional neurology or cardiology, there are time-limited treatments where we are responsible, and then patients are referred back to their regular treating physician. This could be the family physician, this could be the specialist. So the form requires the referring physician to acknowledge this, and it's a single referral form for all the treatments offered within the program. We're able to maintain the volumes within the interventional program because of this model. We don't take over the entire care of the patient. We take over the care only when time-limited treatments are delivered. So this is how we have brought together the different components. I showed the three arms, and this is the flow within the program. At the center, you see the clinical arm. So this includes, so we get referrals for patients who have failed first, second, third line pharmacology psychotherapy treatments. We start at RTMS, and it's a staged, sequenced set of treatments: IV ketamine, ECT. This is the clinical arm. on, you see experimental treatments, take-home brain stimulation, and other treatment modalities. This is the experimental arm. People who have failed the clinical treatments have the opportunity to exit at different time points or, later. On the other side, you see the digital monitoring component. It's a largely digital clinic, which we are developing with specific active and passive data capture modalities in place. So this is another rendering of the same flow. So I showed you the clinical arm, the research arm, and the digital setup, and the various modalities here for data capture. So this pictorial representation, I hope, gives you a better feel. And I'm going to go into specific details, within the experimental arm and the clinical arm over the next couple of slides. But I still want to give you a good sense of what an interventional program is about. So the idea is non-siloed care with interventions coming around the patient rather than the patient going to one intervention and the other intervention. And the focus is on combination treatments, not an individual treatment. So the therapeutic context and bringing about change is a key aspect. We also use the clinical trials as a way to probe the brain. So as Dr. Shin was mentioning at the outset, we want to discover the underlying mechanisms when someone improves or someone does not improve with a new and emerging form of treatment, whether it is nitrous oxide or whether it is a different form of brain stimulation. We want to understand the underlying mechanisms. And there's, even when you're looking at patients with treatment-resistant mental illness, where these new interventions are trialed, there's a subset who responds and a subset who does not. Who responds to which, and underlying the mechanisms, so that we can do better for the ones who do not respond. We can iteratively improve the treatment offerings over time. So this is another key component, that we're using the clinical emerging treatments as a platform to also understand the brain in illness and in wellness. So the way we have developed this program, we have two foundational principles. One is interdisciplinarity, and the other is accessibility. So you will see as I go through that this work is really possible because we bring together disciplines: surgery, anesthesia, neurology, neurosurgery, along with psychiatry within medicine, but also interdisciplinarity outside medicine. So I lead the analytics pillar and the AI pillar within the IBEST program, where we bring together biomedical engineering and computer science along with faculty at St. Mike's. The program also looks at the social sciences and humanities aspects of these interventions. We believe that a lot of new knowledge emerges at the intersection of disciplines. And I mentioned that the other core aspect for us is accessibility. The main reason for us to develop the ketamine program was to make treatments like this available within the hospital, the public hospital system. So accessibility with new and emerging treatments being available to people who need them the most is a core component for us. We also have clinical research and education missions as the tripartite key aspects within the program. I want to say that we are focused on the art and science of change. So we may use pharmacology, we may use brain stimulation, but at the end of the day, it is the story that the patient tells us. And how do we make a change in this narrative? How do we make a change in this story? I'm no good, the world is no good, I have no future. The modality doesn't matter. The end point is the change in that story. That is what we mean by making a difference in the lives of patients with treatment-resistant mental illness. So with that, I hope I've given you a quick overview of how we have envisioned, we are developing the program, and what is our overarching purpose and our mission within the program. Now I'll move on towards some of the conceptual paradigms in interventional psychiatry and touch upon a few key clinical offerings. Now, what is interventional psychiatry? So it is a new domain, similar to other interventional domains. The focus is on treatment-resistant mental illness, but also in rapid response. So this is an emerging way of looking at treatment response in mental illness, whether it is with ketamine or rapid-acting brain stimulation. There is an emphasis on quick response. This was noted even with ECT in the past. So this is in some sense a mix of the old ECT, one of the oldest, if not the oldest, among the brain stimulation treatments out there, and some of the newest and the emerging brain stimulation treatments, infusion therapies. But what you'll also note is that there is a lot of interdisciplinarity. People across fields work together to develop new treatments. One thing which I would like to really emphasize, which is distinct about interventional psychiatry, is the focus on the circuit-based conceptualization of mental illness. This started a decade ago when DSM-5 came about, with the research domain criteria being proposed by NIMH. This is in some sense a focus on the sub-constructs within the illness, with a focus around understanding neural circuits in behavior. This is how neurologists have functioned for decades. Where is the lesion? This is in some sense where psychiatry and neuropsychiatry are moving, with the idea, as you can see on the right-hand side here, about having different networks underlying symptoms. And I'll show some additional slides about how there are shared nodes across symptoms and across disorders. So the idea is to target specific nodes of this network neuroscience, whether you do it with deep brain stimulation, going deeper into the brain, or you do it with TMS or other modalities. Depression is the most well-studied or worked out in terms of the neural networks. So a lot of the evidence within interventional psychiatry to date is for depression. There are more than a dozen forms of brain stimulation under development. So this is a series of papers by Michael Fox and his group. So on the left-hand side, if you see figure 2, the sites for invasive and non-invasive brain stimulation with the best evidence of therapeutic efficacy in each disease are functionally connected. So the idea here, again, is that you have shared nodes across disorders. This goes back to the RDoC approach of constructs which are shared across disorders. But not only medical disorders, you also see, Parkinson's, addiction, Alzheimer's, a number of other disorders. So this is the idea of common elements underlying different psychiatric disorders and also neuropsychiatric disorders. This conceptualization actually allows you to target different nodes in a very precise manner. Figure 3 on the other side, again by Michael Fox and his group, resting state functional connectivity between sites of invasive and non-invasive brain stimulation is significantly higher than expected by chance. So I'll give 2 specific examples. If you look at RTMS, you're targeting the dorsolateral prefrontal cortex, a superficial node in this depression network. If you're looking at deep brain stimulation, you're targeting the subgenual cingulate, which is another deeper node within the same depression network. So you can target the network, moving it from disorder towards sense of normalcy by targeting different nodes, either individually or simultaneously, and it propagates across the different nodes. So this is a core idea in interventional psychiatry and for development of new treatments. So let me give an analogy here between interventional cardiology and interventional neurology. If you were to put the treatments in cardiology, interventional cardiology, side by side with interventional psychiatry, this is how it would look. Defibrillation, synchronized cardioversion, the equivalent is ECT. You're shocking the whole heart, you're shocking the whole brain. Cardiac ablation, you remove a portion of the heart with in MR-guided focused ultrasound, you're actually removing or you're creating lesions. Pharmacological cardioversion, you're bathing the entire heart with pharmacological treatments, the brain, if you're looking at ketamine, psilocybin, MDMA. Transcutaneous pacemakers, if you're looking at TMS and other modalities of brain stimulation, the equivalent is a transcutaneous pacemaker. If you're looking at an implanted pacemaker, which stays in place and actually delivers stimulus, it's going now towards a closed loop system. Deep brain stimulation is the equivalent. The other is epidural cortical stimulation. The last one, ICD, which stands for implanted cardioversion defibrillation, the counterpart in interventional psychiatry under research is random noise stimulation. So I hope I've given you, from a clinical perspective, from a patient profile perspective, and also from, an actual disorder perspective, how things are aligned. So the idea here is that the brain is an electrochemical organ. You can bring about the change, as I mentioned, bring about the change in the narrative, which is what we're interested in psychiatry. We're dealing with the mind. Do it with pharmacology, do it with brain stimulation, do it with psychotherapy. Mind is what the brain does, or with lifestyle interventions, with mind-body interventions, where disorders like depression they're systemic, and there are different ways to target them. Within brain stimulation, you can bring about the change in the electrical side of the equation, either with electricity itself, like ECT, shock the whole brain. Deep brain stimulation, send electricity to a very specific region of the brain, electric charge rather. TMS, which is electromagnetism, magnetic fields go right through the skull and the scalp. When they get in touch with neural tissue, they induce focal electrical current, or use light through modalities like photobiomodulation brings about changes in the mitochondria, which leads to change in the synaptic potential. Again, the endpoint is electrical there. And exciting emerging modalities, transcranial ultrasound, which again brings about change in the synaptic resting potential. So we have developed the 3 pillars within our program to align with these different modalities of bringing about change. So, whether you speak about the pharmacological side, the brain stimulation side, or the digital side, which has an emphasis on the lifestyle component and the psychotherapy component. So moving on now, I'm going to speak more about TMS and then about ketamine in terms of, giving you an overview of how we have come to the point we are in now. I'm not going to go into the technical details. I'm happy to answer any questions at the end. But as I mentioned at the outset, this is more to give a broad overview of the domain rather than depth in any particular domain, which would be a talk by itself. So within neuromodulation, I mentioned about this circuit-based emphasis, mental illness being conceptualized as circuitopathies. And the idea is to target, as I mentioned, specific nodes of this network. So we need to have a target. Let me take the example of TMS, the dorsolateral prefrontal cortex, which is one node in that depression circuit. Now, the next question is the direction of modulation. Are you going to upregulate it? Are you going to downregulate it? So if you're doing left DLPFC, you're upregulating. If you're doing right DLPFC, dorsolateral prefrontal cortex, you're downregulating, with the end result that the impact is propagated across the depression circuit with repeated stimulation over time. This is a busy picture, but it gives you a quick overview of all the brain stimulation treatments which are out there currently and under development. The x-axis is a scale of invasiveness, and the y-axis, is in terms of how broad the treatment target is. Towards the right, you see deep brain stimulation, vagal nerve stimulation, which is focal. I don't see MR-guided focused ultrasound there. As we move this ECT and MST, which is they're convulsive, subconvulsive, TMS, transcranial focused ultrasound. So these are more focal as compared to in ECT, which is general. And then we have the non-focal treatments like TACS, TDCS, and focal non-invasive treatments, temporal interference, which is an area we are doing work in, and I'll get to that later. I hope that this gives a quick overview of the treatments out there and those which are emerging. So in electrical versus magnetic stimulation, I've mentioned before that the brain is an electrochemical organ. So either change it with pharmacological treatments or with brain stimulation treatments. So people who do ECT would be familiar with the Mector machine there on the side. So the idea is between the two electrodes to actually induce a seizure. As you can see, there's a change in neural activity. On the right-hand side, you see TMS. And what you see is that the magnetic field induces a focal electrical field, which leads to, it is non-convulsive, but the end result is again change in neural activity. TMS is used to measure brain activity. Number of the TMS components can actually give you a sense of the synaptic function, the brain, the status at a certain point in time. But as I've alluded to before, it can also be used to change brain activity. So in terms of measuring brain activity, motor surgical pathologies, pre-surgical mapping, understanding underlying mechanisms, but also brain activity in terms of targeting circuit-based pathologies. This is a quick review of FDA-approved neuromodulation treatments of particular note, vagal nerve stimulation in depression, and as everyone knows, transcranial magnetic stimulation, which has general approval. So I want to move on now towards the first, second, and third generation of TMS. The first generation of brain stimulation, 2007 approval through FDA, was the longer versions with 40-minute or 26-minute delivery of TMS. Pioneering work right here from in Canada, Toronto, and Vancouver, which demonstrated that shorter version, a 3-minute version of TMS, is equivalent to the longer 40-minute, 37.5-minute version of TMS. This led to FDA approval and a shift in terms of clinical practice from the longer version to the shorter version, as the briefer version is, the shorter version is actually non-inferior. So that was the second generation of TMS. So I mentioned that I'm going to give a historical perspective to the current time point. The current emphasis is on the research side on accelerated protocols. So we've gone from 40-minute treatments given over 6 weeks with a person coming every day to 3-minute treatments where we can actually pack a lot more treatments in a given day. So the next step is, why do we need 4 to 6 weeks? Can we collapse these treatments given over 4 to 6 weeks to 3 to 5 days? So can we do, the 50 treatments, with 10 treatments per day, sequenced by the hour? So 3 minutes per hour. So this, the initial studies coming out of Stanford, the SAINT protocol. So the idea is to collapse the number of treatments over a shorter period, but also to personalize treatment. So to actually look at a very specific region within the dorsolateral prefrontal cortex, which is best anti-correlated with the subgenual cingulate, and targeting that specific region in a repeated manner, at hourly intervals, 3 minutes at a time. So this has shown rapid antidepressant effects and later also anti-suicidal effects. And there are a number of efforts to replicate this and look at it with and without personalization. So this is the first, second, and third generation of TMS, and I'll make a segue towards ketamine with this slide. So what you see in A here is IV ketamine and the change in depression scores with IV ketamine. The B here is the pivotal work by Dr. Bloomberger and team showing the shorter version of TMS is non-inferior to the larger version, and C and D are the third generation of RTMS with accelerated protocols, the SAINT protocols with the treatments collapsed over a shorter period. So I'll move over to ketamine at this point. So where does ketamine stand in terms of the different treatments out there? So as everyone knows, with the serotonergic reuptake inhibitors, there's little difference in efficacy between these treatments. It's really the side effect profiles which are different. And there's a huge burden of treatment-resistant mental illness. So ketamine it represents a totally new mechanism of action through the glutamatergic system as compared to the serotonergic system, and it's opened a novel drug discovery pipeline. What's critical is also the rapidity, the rapid antidepressant and anti-suicidal effects, not the 4 to 6 weeks before you know whether the antidepressant is effective or not. It has hours to days, within 24 hours to a couple of days, where people who improve actually show the treatment response. So this is a significant advance. Apart from ECT, there wasn't really anything which had the same rapidity as ketamine has. So I'm going to do, again, a quick history to get to the point here. So this is Edward Domino, who first did the first in human trials in 1964. So the ketamine story begins in the 1960s with it being synthesized by Park Davis. So he in 2010 is looking back at when he introduced ketamine as an anesthetic in 1964. He says, I remember one young lady in particular who was a chronic PCP and later ketamine abuser. She had serious bouts of mental depression. I asked her why she took these illicit drugs. And her answer was, oh, my antidepressants don't work well. He goes on to say he told her to not use them, to take them again and stop it. And he never really thought of ketamine as being an antidepressant. So, ketamine was also used as an animal model for psychosis. So in the 70s and 80s, there wasn't really interest until John Crystal at Yale did the initial studies. And then Karen Berman at Yale did the first human study showing the rapid antidepressant effect. It did not capture any interest in the domain because people felt a rapid antidepressant could not exist until it was replicated first by Carlos Zarate at NIMH, and then there have been a huge number of studies which have shown its antidepressant effect, leading to also, the intranasal version of S-ketamine being studied later on. So just wanted to give you that context and that historical picture of how we've gotten to this point with ketamine for depression. So this is a slide about, ketamine's efficacy 1 day, a week after. Ketamine has distinct effects in healthy and depressed subjects. So what you see here is with the depression scores, there's a change when people receive IV ketamine, but there's no change with healthy controls. On the other hand, if you look at the side effects, that the dissociation, both healthy subjects as well as those with depression appear to have the dissociation. So people know about IV ketamine, so I'm not going to go into the specifics of this, except that it is the subanesthetic doses of ketamine which have shown to have the antidepressant effect. Ketamine has been used as an anesthetic since 1964. It's used as an anesthetic in ECT as well. So the combination of ketamine or ECT or ketamine at the anesthetic dose does not appear to have the antidepressant effect. It's at the subanesthetic 0.5, 0.75. The most well-studied is 0.5, where it actually has that rapid antidepressant effect. It is being studied across disorders, and there are a number of ongoing studies in the works for bipolar depression and other disorders, although the best evidence to date is for unipolar major depression, but there are published studies for other disorders. So that was a single dose, and then there were studies suggesting you often start off with a single dose and then you do repeat dose studies to show that the efficacy is maintained, which is what happened here with IV ketamine. So you see that over time, there's a cumulative effect. So if you see the improvement noted over time here, that is the cumulative effect with repeated doses of IV ketamine. This is a recent study, a really interesting study published in the New England Journal, which compared IV ketamine to ECT. And going back to the sequenced program we have developed, TMS, ketamine, ECT, this study actually looked at 403 participants with treatment-resistant depression who were randomized with non-psychotic depression, who were randomized to IV ketamine or ECT, and the endpoint was really 3 weeks, and it was response, and they showed that IV ketamine was non-inferior to ECT. This is the ELECT-D study. Really interesting work. So I'm going to skip a few things here in the interest of time. You would know about the racemic ketamine, intranasal S-ketamine. Ketamine can be given through any route you can think of. IV, IM, sublingual, oral, rectal, it can be given through any route. The intravenous has the best demonstrated efficacy to date, although there are limited head-to-head trials between different routes of administration. Spravato, intranasal S-ketamine, it has to be administered with the current oral antidepressant and has to be administered under direct supervision. There's a whole REMS system in place, risk evaluation and management strategy. This is largely to monitor the longer term, the immediate and also the longer term side effects with Spravato. This is the REMS form. For those of you who have administered S-ketamine, the form will be familiar. So in the short term, ketamine seems to have limited side effects. And going back to that ELECT-D study comparing IV ketamine to ECT, it is the longer term side effects which we still do not know. There are a number of unanswered questions with ketamine, including the appropriate maintenance paradigm, and also potential iatrogenic ketamine use disorder. Although there's a lot of literature that may not be the case, but we don't really know at this point the long-term consequences, which is a topic for active study. So with this, I'm going to now move on to a brief overview of some emerging treatments, which are 5 to 10 years in the making. And I'll go over a couple of key things and try to wrap up in the next 10 minutes. So we'll focus on new emerging pharmacological interventions and then the neurostimulation interventions. I'll mention about our work with nitrous oxide and stellate ganglion blocks within the pharmacological intervention pillar, and within the brain stimulation pillar, I'll focus on the take-home brain stimulation. So stellate ganglion blocks, what is the underlying idea here? So we have the sympathetic and the parasympathetic nervous system. It is like the accelerator and the brake. The two are in dynamic equilibrium. And there's quite a bit of literature suggesting that depression is a systemic chronic illness and there's a sympathetic overdrive. This same has been said about other chronic stress-related disorders, particularly PTSD. And stellate ganglion blocks have been examined in the context of PTSD in the past with mixed results. So we wanted to look, so we did a systematic review of all the existing literature there, and we embarked on a pilot RCT. This was really to demonstrate feasibility of being able to administer stellate ganglion block for treatment-resistant depression. So we had 2 injections of lidocaine, bupivacaine to the right stellate ganglion. So this was placebo-controlled, and we demonstrated the feasibility of administering stellate ganglion blocks. The most common side effect was Horner syndrome-related side effects, as you can see there, the hoarse voice, the pain, the drooping, which is temporary. Within a couple of hours, it gets better. So we did not see a separation in terms of the clinical scores, but it's important to keep in mind that this was not an efficacy trial. This was a feasibility trial. So this is, you know, a way where we're looking at depression as a systemic illness and actually targeting the sympathetic nervous system and blocking the outflow, leading to negative feedback and improvement in symptoms of depression. That's the conceptual overview. So I've gone over quickly one of our interventional research projects. I'll move on now to the next one, nitrous oxide. Nitrous oxide, like ketamine, is an anesthetic. Nitrous oxide, the history goes back. It's one of the oldest anesthetic agents out there, also called laughing gas, given in the dentist's office. We did a systematic review around all the existing studies with nitrous oxide. There are 4 studies in depression, single dose trials, in principally, which showed a similar kind of pattern with improvement in symptoms of depression like we would see with ketamine. There's also a recent study showing that there's also change in improvement in suicidality similar to what we see with depression. There's one repeated dose study from a group in Brazil where they were able to show improvement in a manner similar to what I showed before with ketamine, where there's a cumulative benefit with repeated doses. So we have 2 studies, one which we're in the process of completing now with 40 subjects with depression who are randomized to nitrous oxide and IV saline or room air with IV midazolam. Our recruitment is almost complete, so we should have the results of this trial early next year. We were funded to start another trial, which we did not because we wanted to complete this previous trial, the 40 subjects with depression. So this trial funded through the American Foundation for Suicide Prevention will compare nitrous oxide to IV ketamine. So the question here is, this is an initial feasibility trial, so we'll be looking at nitrous oxide compared to IV ketamine with the primary outcome of feasibility and a secondary outcome looking at the adverse side effect profile, the withdrawal related side effects, and also to get clinical parameters for a more definitive larger trial. So the idea here is nitrous oxide is inhaled, potentially it could be administered with less intensive monitoring and requirements as is IV ketamine, but also to see the response rates, but also there's a possibility that people who may not respond to one could potentially respond to the other. So this is a sequenced program where we want to compare nitrous oxide versus IV ketamine, but also see whether there's a preferential response to one versus the other. So that's about the ongoing work with nitrous oxide and IV ketamine. So the next 2 things, which I'll quickly go over and then I'll complete my talk, is about our emphasis within the brain stimulation side for take-home neurostimulation. So this has been brought home to us during the COVID pandemic, but also, people get TMS, people get ECT, a number of them get better, but people also relapse. And we want to have something which people can self-deliver in the comfort of their homes to actually, if if they get better, the question is how do you keep them well? So this is the program with a focus on self-delivered treatments. With temporal interference, the conceptual idea, again, I want to give you the big picture as I've done with the different treatments. So the idea is that the brain is a high-pass filter, so it does not actually recognize high frequencies. So you see here 2000 hertz, 2010 hertz. The brain does not recognize 2000 and 2010 hertz. In the areas where the waves actually interfere, so that's the idea of temporal interference, the difference frequency is what the brain recognizes. So by clever positioning of the leads, you can actually target a deeper region of the brain. So in this picture here, you're seeing the difference frequency of 10 hertz being actually recognized by the deeper region of the brain, but the rest is not, as the brain is high-pass filter. So we're doing a trial with Ed Boyden's group at MIT. He and Grossman did the initial studies with animal models. So we have completed the modeling for this, with placement of the leads, as you can see there, to target the deeper regions of the brain. And the trial is just getting started, where the focus is really target engagement at this point in time. Moving on, this is the last modality which I'll mention today, and I'll finish my talk. So this is functional electrical stimulation for depression. So the idea behind this treatment modality is, so this was work closely developed with Dr. Popovich, and a lot of input from Dr. Mulsa in terms of developing the conceptual framework. Functional electrical stimulation has been examined as a treatment for stroke for over 2 decades. So the idea is, if a person has loss of strength in the limb, you would give patterned electrical stimulation of that limb, which would lead to neuroplasticity upstream. So it is the brain that rewires itself. The region of the brain which has undergone cell death is taken over by the region, the functional region, when there's pattern stimulation of the muscle which has undergone stroke, along with the person voluntarily trying to contract that muscle. So we took the same idea towards depression, and we said, could repeated patterned facial smiles have an antidepressant effect? So this is the equipment developed at Toronto Rehab by Dr. Popovich and his team. This is the Mind Move device. And what you see here is pattern placement of the leads leading to a particular pattern of facial smile called the Duchenne smile. So we're part of a healthy cross-section study where there was noted change in terms of affect, and also a 10-subject open label trial where we were able to show that there's an antidepressant effect. So we are in the process now doing 3 trials where we take a picture of the person's face and we're able to develop a customized mask, facial mask, which will actually deliver this patterned facial smile in a repetitive manner. So one trial is using 3D printing to develop this facial mask and deliver it like we would do TMS. You can imagine that if you have the facial mask, people can self-deliver it at home. We're doing another trial with an in-person delivery. This has an imaging component, and we're trying to map out the neural circuitry underlying this, the improvement in this treatment. And the third is a fabric-based delivery. So we are embedding sensors into a facial mask, which people could wear. It's like the 3D printed mask, but this is a soft facial fabric which people could, which is actually customized to that particular person's face and delivers personalized FES parameters in a repetitive manner. So we have 3 studies which will be starting sequentially. So with this, I just want to thank the team members. We are people across universities, U of T, Ontario Tech, particularly the digital group, and also different hospitals and research institutions who have contributed to this work. I'm really thankful to our large investigator team, particularly to people, Dr. Shin, Dr. Malsa, Dr. Kennedy, Dr. Bloomberger, and others who have really helped move some of this work forward. As I mentioned at the outset, we are a very interdisciplinary team. So you see people from anesthesia and neurosurgery, particularly engineering, computer science, but also nursing, informatics, and psychology. So I would also like to thank our funding bodies, nationally, provincially, locally, internationally, also the support we've had from industry. And I really want to thank our team. The current team, we have a strong educational focus and an educational mission. The postdoctoral students, the doctoral students, a lot of what I have presented is because of them, and it is their work, and also the alumni who have gone through our team. So with that, I'll stop, and I'm happy to take questions.
Thank you, Dr. Bhat. That was a really insightful talk, and I really appreciate you talking about this, very, very important topic. We've got a couple of questions, and I'm going to start off with the first question. It's a question about, there was a recent research article in Nature Mental Health about some of the challenges of masking, in ketamine and depression, and I think they were trying to do masking and to see how that would be effective in terms of RTCs, etc. What are your thoughts on this part, proper masking and RTCs, and with respect to ketamine and psychedelics?
Yeah, it's an excellent question, and one needs to be really mindful of the placebo effect. And that's been the case with almost every new treatment which I've shown there. There's, the initial large effect and then the regression towards the mean, and also carefully selected, the inclusion criteria and exclusion criteria are very strict for the initial trials. A lot of the initial trials are often open label trials, and the reality of the effect size really becomes apparent over time. So I think, and that's partly why we really need to do systematic, well-conducted research. Also, looking at real life outcomes where people don't fit DSM the way we characterize them into a particular disorder. People have comorbidities. There's also difficulty with respect to actually doing placebo-controlled trials. With some studies, there are practical challenges. So particularly with ketamine, there have been recent studies suggesting that the effect size may actually be a lot smaller than what has been reported before. On the other hand, we also have recent trials like the one I showed in NEJM comparing IV ketamine to ECT, and showing that IV ketamine was non-inferior to ECT. So this requires to be replicated, but that was a well-conducted large trial with 400 subjects who received IV ketamine and ECT. So the bottom line is that the effect size is probably a lot smaller than what the initial studies have shown. And also, as you add comorbidities and you go into real life settings, it also raises the important question of wanting to look at ways to optimize treatment response. Why is that some improve? Why is that when people have those comorbidities, they don't? And also the need for, a number of other treatments if people don't respond to, let's say, ketamine or to brain stimulation.
Yeah, definitely. Thank you. Thank you for that thoughtful answer. But there's another question, maybe I can ask two questions from their question. One of it was, one aspect was, is there some type of addictive potential with ketamine? Let's maybe start with that. What are your thoughts on that?
Yeah, so this has been raised as a critical question, and a lot of the initial trials excluded people who had a history of substance use. So going back to the previous question about, what's the efficacy, but what are the side effects when people have real life comorbidities. So this will become apparent over time. We as a program are careful, when we do eligibility for IV ketamine. If people still meet criteria for substance use, at this point, we're not offering IV ketamine until the, status of the field evolves there. Our objective is to first do no harm. So until, as a clinical program, if it's a research component, it's different. But as a clinical program, we're not offering IV ketamine if people have active substance use or they meet criteria for substance use. We don't have good answers in the long term, and even the acute efficacy trials are up to a year with intranasal, not really longer than that. So would a course of IV ketamine rekindle lead to an iatrogenic substance use disorder in the long term? That's an open question. One also needs to keep in mind that ketamine is being actively researched as a treatment for substance use. Like you have studies, well done, controlled trials with ketamine and psychotherapy, ketamine itself for alcohol use disorder. There are a number of ongoing studies for other substance use disorders. So, that's a different outcome, and specifically for people who have substance use. But if the question which was asked was, if someone comes in with depression, what's the probability for them to develop a substance use disorder in the longer term? That question remains unanswered.
Yeah. Okay. Thank you. The second part of the question was, is there any sort of studies, or are you planning to conduct any studies to look at the efficacy of ketamine monotherapy versus ketamine and psychotherapy treatment outcomes, response rates and treatment to resistant mental health populations?
Yeah. So at this point, we have looked at the two separately. There are other ongoing studies. There's a published study looking at a single dose of ketamine and psychotherapy. There are also people looking at combination of CBT along with IV ketamine. So that's in the works in terms of ongoing projects. At this point, we're not doing specifically ketamine and traditional psychotherapy, but we're looking at psychotherapy delivered through innovative modalities as potential combinations with IV ketamine. We don't have that trial yet, but that's something we're thinking of.
There was a question about, are you trying these modalities in geriatric populations?
So the best evidence for, when you say these modalities, do you mean ketamine or do you mean?
Yeah, maybe start with ketamine.
Yeah, so with ketamine, we get 6 to 8 referrals per week, and we have, with the capacity we have tried to look at, who would likely benefit the most and where's the best evidence. As I've mentioned before, if there isn't evidence for ketamine to be given in a certain context, we're not. People who are more severe, we are prioritizing them to get it. The evidence is also best for the adult age group. We don't do below age 18. So 18 to 65 is the group we prioritize. We don't exclude people with geriatric depression, although they might not be the first to receive IV ketamine like the adult population. We also consult with, if there's any concern with cognition and aspects like that, we work with the geriatric psychiatry team. We also have a neurologist as a part of our team, and we consult with the neurologist as well. So we do more evaluations, if I can put it that way, on the geriatric side. We don't exclude them though.
Okay, thank you. I'm sure they can connect with you if there's further follow-up. There's this question about, I think they were thinking that you have a study looking at interventional approaches to post-stroke depression. Do you have any initial impressions about that, that study or something that you're working on?
So that's a good question. We are a front-end clinical program. So we have not excluded, as I've mentioned before, particular subpopulations, and that includes people who have stroke and depression. We work with the neurology team to ensure that they're also comfortable. We have administered, and we also look at Parkinson's and depression, where we've received quite a few referrals for IV ketamine. We are working to have focused protocols around that population so that we can also, triage them to receive IV ketamine. At this point, it's more a question of capacity, and with the capacity we have, what populations do we prioritize it where we have the best evidence?
Yeah, thank you, Dr. Bhat. I know there's lots of thank yous on the chat as well. Thank you for this very insightful talk. I don't know if Dr. Shin is still around, if she wants to say a couple of words, but I really want to thank you for this wonderful presentation. Dr. Karen, you want to say a couple of words?
Yeah, I just wanted to say I appreciate everyone attending, and it's been a pleasure and a privilege to co-host this citywide Grand Rounds. It's exciting research that's happening, and the fact that a lot of it is clinically driven. So being able to actually offer treatments for people that might not be able to access it in other ways, I think is the key aspect. And we need all this research really to drive new treatments, because there's still so many people that are struggling, suffering with mental illness that we need to find effective treatments for.
Very nicely said, Karen. And I want to thank everyone for joining as well. And we will see you next month. It's the Paul Garfunkel lecture, and we have a really interesting talk on quality improvement from someone from the UK. So hopefully you can join us then. So take care. Thank you.
Thank you.